So, as mentioned, I'm absolutely delighted to be joined by Professor James Field tonight, who's going to be delivering the presentation. Some of you will know James. He's Director for Learning and Teaching at Cardiff Dental School, as well as being a Professor of Restorative Dentistry and an Honorary Consultant in Prosthodontics. James is also a key opinion leader for Dents by Sirona and has delivered lost count of the number of training and webinars and projects that you've done for us, James, over the years, both in the UK and overseas. But suffice to say, James has got so much experience with delivering these sorts of innovative teaching methods. Some of you may not know, James also holds a Master of Arts degree in Education and a National Teaching Fellowship. So as I say, I'll come back to you towards the end of the presentation, but please do get involved if you've got any questions. As I say, either type them into the chat or come off mute if you're feeling brave and feel free to chip in. But for now, I'm going to pass over to James and let James take over the presentation. Thanks very much.
That's great. Thanks, Christian. And thanks, Emma. Hi, everybody. Real pleasure to be here this evening. Yes, we are small but mighty, 20. But I know some of you I can see I know very well. Some of you I'm not so sure. And some of you are very significant blast from the past. So it's a real pleasure to be here, to be speaking to you. I'm just going to share my screen and make sure this is working okay. Here we go. Hopefully, Christian, you can let me know if that's visible okay.
Absolutely fine, James. Yeah, coming through clear.
Great. Okay. So yeah, as Christian says, I've been doing things with Dents by Sirona for a little while now, and he asked me if I would put together this series of webinars, and the focus really is on back to basics for a number of reasons. Not least at the end of a busy day, our brains can cope with very little more than what the day's thrown at us. So back to basics is probably useful. Particularly, and I hope some of your cameras are off because you're actually sitting in the evening sun. I'm inside, as you can see, but hopefully you're not. Back to basics because we often, once we've qualified and we get out into the big bad world, we often forget. And one of the kind of the liberties really as an academic is sometimes it can be a double-edged sword, but we're forced to go back to basics a lot. To teach things, to reteach things. I know some of you on the call are teachers still, and have been teachers for a while. But they say the best way to learn something is to have to teach it, and no more true words in this respect. So I make no apologies for some of the things that I'm going to talk about, and that they are basic. But hopefully, what they'll do is just trigger a few thoughts in your minds as we go through the different webinars. And tonight is very much setting the scene, but it should start your thoughts flowing a little bit around some of these concepts, because sometimes the decisions that we make and the things we decide to do are based on habit rather than kind of sound science. And it's really important that you're able to question what we do and to make the right choices. Hopefully, going back to basics will enable you to do that. So again, working with that amalgam, that's the theme around these webinars, and it'll become clear as I start to go through a few more slides what we're going to cover. But in this particular webinar tonight, we're going to talk about the phase down of amalgam briefly. It's kind of happened. It's kind of been imposed on us somewhat in terms of our ability to source amalgam anymore. So we won't labour that point too much. But we're going to talk about how it might impact our choice of direct restorative approaches. And we'll look at the materials and the properties and their indications that we can use for directs. And then we'll think about some of the challenges that are posed by not being able to use amalgam anymore. And some of you will be very well aware of those. And we'll talk about how composite could be used in preference or as a solution. So very briefly then, we're pretty clear on what the problem is, but we've waved goodbye to dental amalgam. And yes, some people still have some stocks of it. Our hospital still has some, but we won't be getting any more. And actually, some people are probably squirreling a little bit away for a rainy day or for particularly challenging cases. But the EU's phased out dental amalgam under the particular EU regulation, and that's been coming for a little while now, since 2017. But the legislation now prohibits the use and the manufacture and the import, and really importantly for us, the export of dental amalgam in the EU. And this is why we find ourselves in the position that we're in terms of not being able to source amalgam anymore. And that essentially came into effect at the start of this year. So we are well and truly into 2025 now. So I'm not going to labour this point too much. I mean, those of you that certainly went to dental school in the UK may remember the length of time that was spent talking about amalgam, the science behind it, the chemical composition, the eutectic mixture of metals, the phase diagrams. It sends chills down people's spines. And we still had to teach all of that until relatively recently. And I'm pleased to say there's less need for us to labour those points anymore. We have to focus instead on more contemporary materials, which bring their own challenges for students. But really, all we need to know is that amalgam is a mixture of metals, a very clever mixture of metals. Prior to the ban, its use was highly regulated already in the EU in terms of how it was produced, how it was mixed, and how it could be applied, and also how it was disposed of. And actually, we've been really heavily regulated in the UK on a lot of those aspects for a while, even though parts of the EU were a bit later in catching up with those regulations. But anyway, there were still many public concerns over mercury toxicity, even though there was very little evidence to link dental amalgam to any observable disease process. And aside from kind of immunological conditions linked to amalgam and the contents of the metals, it was very difficult to try and rationalize why it was a concern in terms of disease and pathology. So why was it used? Well, those of you that might be shedding a little tear at the moment and not having ready access to amalgam anymore will appreciate a lot of these factors. But it was a cheap material, and it was incredibly tolerant of moisture. And that's one of the big challenges that we're going to talk about over these subsequent webinars is how we find ways of substituting what we were doing with amalgam in those challenging cases. It was very strong and durable. And yes, it wasn't as strong at the point of curing a composite in terms of time, but it was a very durable material once it had gone through its full phase set. And actually, as a material on the shelf, it lasted a long time. And despite having to use an amalgamator, it was simple to mix, and it has a very long track record. The other thing which wasn't immediately obvious with amalgam, which made it such a good material, was that it developed a corrosive seal around it as it was exposed to the moist oral environment. And this is heavily debated in academic circles, but some people would argue that corrosive seal that formed was actually a very useful thing. Probably not as hermetic as kind of a well-placed composite bond, which has chemical and micromechanical retention. But in the most part, it provided a good seal for the restoration and reduced recurrent caries. That said, a lot of people argued the opposite and said, well, but I place a life lining, a calcium hydroxide lining under my amalgam, and it became evident as teeth were extracted and restorations were lost that those linings disappeared. Or you're probably well aware of the concept of disappearing dical. It used to just disappear from inside there in some miraculous way, but it probably was due to early microleakage, which then developed a seal later on. But it was also excellent as a core material because of its strength, tensile strength, as well as its compressive strength. And actually, practically, it had a low number of biocompatibility issues. I can see we've got people on the call tonight who have done a lot of work with composites, and any material that we're using that does what we want it to do will come with its own challenges in terms of the environment and in terms of biocompatibility. But amalgam actually had very little by way of issues there. However, we've mentioned before, we saw lichenoid reactions and big public concerns around toxicity. And in the end, political pressures meant that that this was phased out, because actually the use of dental amalgam only made a very small proportion of how mercury was used in the modern world. A lot of it was, if you think about kind of battery production and other industrial processes. But the other issue that a lot of patients had, particularly in the NHS, were around aesthetics. And I suppose this drive to composites satisfies things on a number of levels for patients in terms of the concerns they had, the health concerns, and also aesthetic concerns as well. The other issue with amalgam was that it was non-adhesive, and some people argue that we had to be much more aggressive in our preparations to give our preparations retention form as well as resistance form. And I'll talk a little bit, perhaps in the second webinar, about why we still need to respect basic principles of cavity design, even though we're using a composite which essentially will adhere or micromechanically retain itself to tooth structure. And why it's still a good idea to think about resistance and retention form as well. So I just want to pause for a moment and think about some policy here. And at this point, we're going to have a little look at ISO standards. And again, I see a few people on here as attendees who have done a lot of work here and have published in this area, particularly around some of the restorative materials. So it's a real pleasure to have those people here tonight. But the ISO standards are international standards, globally recognized standards that provide a framework that is meant to improve management systems and operations. And the standards actually exist for many, many things, including environmental sustainability, but also for the materials that we use in dentistry. So they exist for dental amalgam, they exist for composite, and they exist for what are called glass polyalkanoates, which is glass ionomers, as we often refer to them. But most people don't know about them. And actually, when we buy these materials, they have to adhere to these international standards. And this is the first point at which we go back to basics, because I think it's really useful. You know, you're using these materials all day long, should understand what the basic requirements are for these materials. And it can help you to differentiate different characteristics between different materials as well. So if we have a little look at amalgam, ISO 1559, then this is quite interesting. The ISO standard stipulated that the amalgam must be made of a powder alloy and a mercury mix, but it also made some other stipulations as well. The alloy had to be a minimum of 40% silver, which often surprises people. And it had to be a maximum of just under a third tin and a maximum of just under a third copper. And it also had some other things in there to scavenge free radicals and also to prevent creep corrosion. But interestingly, it had a maximum of 3% mercury. When you talk to people and patients and actually other oral health professionals, there's a misconception that dental amalgam had a huge amount of mercury in it. And what the ISO standards said is that there had to be limits to the dimensional change that could happen with amalgam during its set and thereafter. And it also had to develop a certain amount of strength at 1 hour and then also at 24 hours. And we'll all be aware, when we used to use amalgam, of finishing it and then telling patients to be careful on the restoration for the rest of the day or until the next day. And that's because it was going through its kind of second phase set. And also there's a requirement for the material not to change dimension or to creep more than a certain percentage as well, because amalgam did do this to a certain extent. So let's move away from that anyway, because we're not using amalgam anymore. Let's turn our attention to composite, and this is bound by the ISO standard 4049. And I think it's really useful to go through some of these characteristics because, again, we often forget what we're using and the kind of the material that we are using and the choices available to us. But composites have to, according to the standard, comprise a base resin, which is usually methacrylate or acrylate based. And then it has to comprise fillers, which go into that base resin. And mixed together, it makes this kind of paste of varying viscosities, which we can use to apply into cavities or to shape into different shapes before curing. Now, the fillers might be made of quartz, they may not be made of silica or barium, or like some of the dense Sirona products now, and have been for a while, but the filler might actually be made of some of the cured composite itself, which actually is a very clever way of producing filler. And it's a way of ensuring that the filler remains better bound to the base resin, which reduces things like crack propagation and failures, kind of cohesive failures. But we'll talk about more that much more in the subsequent webinars. There's something called triethylene glycol dimethacrylate, TEGDMA, which controls the viscosity. And some of these, when you go to the DS and other companies and look at all of their labs where they're making composites, a bit like a Willy Wonka showroom, you've got some kind of these materials which are very thin, and some of them are like treacle, very, very thick. And obviously what companies are doing is getting different ratios of these base resins together to give the composite a certain degree of sculptability, viscosity, all the properties that we see with it, self-leveling, etc., bulk cure. It's all a clever mixture of different base resins and fillers, filler types, filler shapes, and how they behave under loading, and when being cured. So it's a real science. And in there as well, we have some what are called activators and initiators, which is what determines when that curing cycle begins, and when it does begin, how that moves through material, and make sure that as much of the material as possible is being cured and polymerized. So the ISO standards say a few things. They say, first of all, that the minimum depth of cure for any composite has to be 1.5 millimeters. For them to be sold as dental composites, they have to do that. They also have to have a minimum of 50% conversion of their monomers to polymers. Now, this is the first standard that part of the standard that's always concerned me. I think 50% is very low. Most modern composites are way higher than that. And maybe there's a need to update the standards, because you'd expect that more than 50% of the monomers, or you'd hope that more than 50% of the monomers are being converted. Because as we'll see further down the standards, there are also requirements for how much of the constituents of the composite can allowed to be leached in and out of that composite once it's in a moist environment like the mouth. There's a minimum of 80 megapascals flexural strength, which is reasonably strong. And here, there's also a maximum amount of water that can be brought into the composite once it's in a moist environment. You might think that when you cure it, that nothing happens and it's completely impervious to anything, but really any composite system will imbibe water into its structures around the edges and into its matrix. But it's stipulated that has to have a limit. What happens when when it takes diluents into the structures, that it starts to degrade composites, and this would happen to any kind of resin composite, but it would degrade over time. There's also a maximum amount of water or fluid which can come out of the material as well, because also when it comes out, it brings parts of the system which have been uncured or unpolymerized with it, such as formaldehydes and methacrylic acids. And I know some of you, again, here tonight have done some work on this, and it's not a hidden issue, but actually it's not necessarily so obvious to the public that any composite system is based on the curing of these types of formaldehydes, methacrylates, etc. And we want to try and minimize that, because actually they're not great biologically, and we don't want them to be continually leached from these materials. Interestingly, for me, maybe for you as well, one of the issues that we have with curing composites is the polymerization shrinkage that happens with them, and the stress that might apply to the walls of a cavity as the composite cures. That is actually not stipulated in the ISO standards. And again, perhaps another reason why these standards should be updated, because nowadays we do want some indication of how much stress might be caused on polymerization, and we would be a good idea to minimize that and to have that as a certain maximum that could happen in the standards. So again, just a little bit of insight there into what composites need to do before we go any further. And finally, the glass ionomers, the glass polyalkanoate cements, have their own standard as well. And just to remind you, these are acid-base cements that can be used in a number of different ways. You'll use them in various ways in your practice, from luting and lining to fissure sealing to staged caries removals to bases of restorations, etc., or as a resin modified form for definitive restorations. And these are made of a polyacrylic acid and a powdered glass, and when mixed with water, will go through a reaction which forms essentially a cement over time. So the ISO standard stipulates how long these have to set by, if they're used as restorative materials or lutes, and how strong they can be, again, if they're used as restorative materials or lutes. And interestingly, a lot of people forget this, but when we're using glass ionomers, we should condition the dentine with a polyacrylic acid. If we're using phosphoric acid, it's often too aggressive for dentine, and it's often assumed that we don't really need to condition the dentine at all, but you will get the best result by using a relatively mild acid like polyacrylic acid on dentine before applying a glass ionomer. And of course, often touted as a huge benefit of glass ionomers, but we have fluoride released in acidic conditions, particularly in the early life of the restoration. It's not quite enough to prevent really caries from happening. A lot of you that treat high caries risk individuals will appreciate that just having this condition of fluoride release in itself is not really enough, but it will go some way to preventing demineralization around the restoration. And of course, it's a cement, so it can dehydrate. And if it's in a particularly aesthetic area, then it should be varnished. A lot of people don't do that anyway. But really, if you're going to have the mouth open for a long period of time and placing glass ionomers, then we should consider applying a fluoride varnish over the surface. And unlike the other materials, glass ionomers forming a chemical ionic bond to enamel and dentine. So it's the calcium in the enamel and dentine which is bonding to those carboxylate groups in the polyacids. And again, these standards stipulate that the bond has to reach a certain threshold in 15 minutes, which optimizes over the next 48 hours. So, time to dive into a little bit of research. And this is where I'd like to bring in the first, what I think is a very interesting paper by Oliver Bailey, who's based in Newcastle. And this is largely written by the Newcastle team. And it's a few years old now. But essentially, what this study was looking at was UK-wide, surveying over 1,500 general dental practitioners. And no surprise, but it was showing that the most commonly used restorative material in molar teeth was amalgam. And this was across all different, NHS and private practices. Interestingly, though, the study showed that dentists and therapists took 45% more time to place molar MOD composites than they did with amalgam. And largely, people had concerns over the suitability of composites for those larger restorations. And a higher complication rate was reported for large posterior composites. And I guess what that's showing us is that amalgam habits, whether we like it or not, are deeply embedded in UK dentistry. And we need solutions to overcome some of the actual challenges, but we also need to talk about things like this tonight because we need to overcome some of the perceived challenges. A lot of this is perceptions rather than real practical barriers. And it's about that culture shift from amalgam away to materials which, if you remember the messages that a lot of us were given when we were at dental school and left dental school, it was that composites don't behave very well in large restorations. But we're so far away from that now, and there's so much evidence to show that that's not the case, that we need to move forwards and we need to actually begin to use composite confidently, knowing that it's an acceptable material. We need to talk about sustainability, of course, as well. And here we've got a paper from Brett Duane of Trinity College, Dublin in Ireland. And this is a very interesting paper because it looks at how dentistry impacts on the environment. But what's interesting here is that the biggest carbon footprint in oral healthcare actually comes from patient and staff travel, over 64%. A lot of dentists and our students, when you ask them, think the biggest environmental impact from dental treatments comes from plastics and waste materials. But actually, the biggest way that we can have the quickest impact on reducing impacts on the environment is to not bring patients into the office as often, and to do things well and effectively. And we also know that when we're talking about rehabilitating patients with composite, that they have a real potential to fail, and that's most likely because of inappropriate bonding protocols, especially to dentine. Amalgam, we had to build in retention forms. Sometimes we bonded amalgams into place, but that wasn't such an issue. But with composite, we need to think carefully about how we're choosing to bond to those various substrates, and we'll cover this in the future webinars. If you think about all the times that dentine is exposed and we're bonding to it, and the way it presents in different ways on different occasions, we need ways in which we can identify how it's presenting and then make a good choice that's predictable and robust, that will result in a restoration that will last as long as possible. So the message here is do it right first time. Don't have to repair things, don't have to bring patients back, and that actually in time will make a significant difference to sustainable practice. So let's turn our attention now then to ways in which we can overcome some of these perceived and actual challenges with the use of composite. What's going to determine how successful anybody is when they're placing large posterior composites? So we can optimize our outcomes by doing a few things. First of all, we can make sure that we're minimally invasive. I'm going to talk a little bit about this in a minute because, and I hope that a lot of you are well versed with a minimally invasive approach. But the term is often used, but then the way people practice is not necessarily minimally invasive. It's probably just operatively careful, which is actually quite different. So we'll talk about that in a second. And ensuring that we prepare our teeth carefully and that we actually prepare them to recognize criteria. Again, sometimes when we go back and look at the characteristics of a preparation, there are aspects of it which, again, we forget about trying to build into that. Also, making sure that we've got adequate adaptation of matrices is really important. Whatever matrix system we're using, if we don't adapt it well, then we either end up with poorly contoured restorations, which we then have to adjust, or we end up with voids or excess material, particularly around the base of boxes, which, if it's noticed, is hard to manage. Sometimes, though, is unnoticed and causes other problems. And again, we want to make sure that we're optimally bonding to the substrates that present to us for the restoration. And also, we want to make sure that we contour and finish our restorations appropriately. With amalgam, we overpacked and we carved it back, and it was a very tried and tested approach. We relied on the existing tooth structure with our instruments to rest on, to guide us, and it is very much an art to carve amalgams back. But it's entirely the opposite with composite. We don't overpack composite and carve it back. We actually have to place it as we want it to be before we cure it, and hope that we would do very little to it afterwards, other than perhaps polish some areas or make some minor adjustments. This is something that we found our students, when they transition away from amalgam to composite, find very difficult. They often overpack and have to cut things back afterwards, which is a challenge. And finally, we can be successful by ensuring that we make appropriate decisions about the restorability of teeth. And I'm going to talk a little bit in the future webinars about where we find our margins. And it goes back to the idea at the beginning that amalgam was very forgiving. It was very easy during that setting phase to manage lips or ledges, or to pass instruments into proximally. With composite, it's different, and we need to be careful about how predictably we can bond, certainly subgingivally, where it's moist. And they're not problems that you would see immediately. You would think, oh, I've got a nice restoration there. It looks good on the radiograph. But then you would start to see problems that creep in, which we'll talk about later on. So minimally invasive dentistry, again, I make no apologies for just going back to this briefly because it is back to basics. Um, this is a systematic respect for natural tooth tissue. But what does that mean? And I find this actually really challenging to teach to our students, to our undergraduates as a concept, because it doesn't just mean doing as little as possible, which is what a lot of them think it means. It's kind of it's more subtle than that. It's about not operatively removing tooth tissue when it's not necessary, but in many occasions it may be entirely necessary and justified. So really, it's all relative. If we look at this kind of case, what is minimally invasive? Doing nothing is not a minimally invasive approach. It wouldn't be effective. We have a patient here that presents with amelogenesis imperfecta and has had a number of composite restorations tried and are failing, and the teeth continue to fail around the mouth. So actually, our solution needs to be, in the end, more aggressive, but we're still being as minimally invasive as we can be. So it's just to make the point in any of these types of cases that it's all relative. So in the end, if you end up picking up a handpiece and doing something operative, so long as you're doing it in a respectful way of tooth structure and tooth tissue, then that's okay. So it's just to make this point that minimally invasive doesn't mean not doing anything or just watching things until things start to fail. So we're going to go back just for a second to the policy lab because we're going to look at the ICCMS system. I hope that a lot of you are aware of ICCMS, but then it's very understandable if you're not. I don't think really enough people talk about this. It's a good way of classifying and managing the caries process. So ICCMS stands for the International Caries Classification and Management System. And we also have ICDAS, which was its predecessor, which is the International Caries Detection and Assessment System. And that's a system for classifying and assessing caries. The ICCMS is a bit more of a comprehensive approach, which is for managing caries based on risk. You can see a little diagram there on the right that talks through the different stages, the 4D approach, as it's called, caries care. Detecting, deciding, doing, and determining, and risk-based recall intervals. And so the ICCMS system builds on ICDAS, and it provides a very comprehensive approach to caries management. Now, I've put a QR code up there so that you can take a little screenshot of that, or you can follow it through, and it'll take you to a very big document. It'll take you to the ICCMS guide or the ICDAS guide. And if you're aware of that, then that's fine. But what I've done is over the next few slides, I've just taken a few snippets from there to explain how things are classified. Because again, very different times now, but we are expecting practitioners, certainly our recent graduates, if they see caries, to be classifying it based on ICDAS and to be suggesting a management approach which is based on ICCMS, and to be talking about that and recording it in the patient's notes. So again, I think it's really important that we're talking about this if you're not fully aware of how that works. And of course, we only operate when necessary. And what this first of all does is allows you to try and classify how caries might be presenting on tooth surfaces. So ICDAS code 0 would be sound tooth surfaces, no evidence of visible caries. And of course, all of this relies on teeth being clean, dry, and well lit before we're making that judgment. ICDAS codes 1 and 2 are initial stage caries, and here we start to see kind of early visual changes in enamel, that chalky appearance or that opacity, the white spot lesions or the brown discoloration, which wouldn't be consistent with sound enamel. And that would be given an ICDAS code of 1 or 2. But this hasn't cavitated, it hasn't collapsed, there's no surface breakdown, and there's no underlying shadowing of dentine either. These are also accompanied by classifications which you can give radiographs. Typically it would be bite wings, but you could give these an RA code based on the extent that you see. And of course, something which we always should do is to marry up our clinical presentation with our radiographic presentation before we come up with a diagnosis. So many practitioners still are panicked by the fact that they have to be making a diagnosis just from the clinic or clinical appearance or from the radiographs alone. And of course, we need both. We need both to come together along with the patient symptoms to make a judgment about what's happening. So ICDAS codes 3 and 4 are moderate stage caries. And here we've got localized enamel breakdown. So we've got visible dentine exposure in the bigger codes, but here you've got collapse. You've got collapse of the enamel. And you may also have a significant underlying shadow of the dentine as well. Obviously, we don't want to go prodding things with our probe because we might cause further collapse, but you can gently explore the surface with a round-ended probe just to feel if you've got a lack of continuity of the surface of the enamel or to see if that ball end kind of drops into any cavitated areas. And then we've got more extensive caries, that's codes 5 and 6, which is a distinct cavity with visible dentine exposed. And they're pretty obvious when we see those. And again, they're accompanied with different radiographic classifications as well. So when you put these things together, what the guide explains is that we have the radiographic categories across the top, and then we have the clinical categories down the side. And this will allow you, when you marry them together, to give you an idea of the extent or the severity of a carious lesion. And there's a concept talked about in the document, which is tooth-preserving operative care. And if I just leave this diagram up for a second, what you can see is that we have some different presentations. And initial active lesions would either be managed by non-operative care, which is NOC, where we're applying topical fluoride, we're giving oral hygiene advice, and we are removing the biofilm. But we could also use resin-based sealants or infiltrants as well to try and reduce that carious process. You'll notice as you look down the table, though, that lesions become moderate and active. And at this point, there is an evidence-based approach for tooth-preserving operative care, so being as careful as possible to remove carious tooth tissue, particularly around the periphery of a lesion, which allows a well-sealing restoration to be placed to seal that into place. They could be, again, the same types of sealants, but this is where we're really talking about the use of composites at this point in time. And the only other reason where we might do tooth-preserving operative care is if we have inactive lesions, but we have aesthetic concerns from the patient, or we have stagnation areas which are going to, or highly likely, to become active again because of the anatomy. So you can see those two areas there represented with red arrows. So let's go back again then to clinical solutions. So really important to think about how you're preparing. If you are going to remove tooth tissue in an approximal lesion, for example, posteriorly, you're going to actually take the burr to the tooth to remove carious tooth tissue and to gain access. How are you doing that? This is something which I've talked for Dentsply on for many years and end up in person having loads of discussions with practitioners about this. Believe it or not, it's something which a lot of people are still quite hesitant to do. A classic class 2, as we used to refer to them, the posterior approximal box needs to do certain things. And if it doesn't, then it causes problems. So, it has to clear the contact point. Contact point just below it is the area of stagnation, and it's the area where that carious process is most likely to begin. It's the area on your radiographs where you will see that radiolucency starting to its way through that thickness of enamel, and in the end, punching through to start to infiltrate the dentine underneath. We see lots of situations where people don't clear the contact point, and we get recurrent caries. So it's really important that we do that. Good idea, as you can see in the diagram at the top, to have cavo surface angles of around 90 degrees. And that means that we've got a degree of robustness both to the tooth structure that's left, but also the restoration that we're placing. If we allow those cavo surface angles to become acute, then we find that we either get degradation of the margin because we get slight microfractures or larger fractures of tooth structure or of the restorative material. And actually, bonding things in place isn't really just enough to stop that from happening. And even if the pieces did stay in place, you still have fundamental kind of cohesive failures in your restoration or at the tooth interface, which will cause micro leakage. And we have to protect the pulp. And I've put a couple of diagrams just on the bottom there to remind people. And again, this is really basic, but I make no apologies for talking about this. A lot of the time, dentists will operate from the 11 or 12 o'clock position with their patients. And many of you will have done this for decades and decades. But we see a perpetual problem as we go further back in the mouth with people forgetting to check angulation and that long axis approach to preparing a box. And we see lots of referrals into the hospital. I see lots of referrals where people inadvertently have made mistakes around angulation. And you can see how if your burr is angled too far mesially, then we risk damage to the adjacent tooth, but we actually then also don't prepare any resistance form to a box. It's just a slope. And we're not effectively clearing the contact point. And there's no axial support by way of a floor to the box. All those things will result in our composites failing more quickly. And if we angulate our burr too far towards ourselves, then we actually miss clearing the contact point often. We endanger the pulp and we end up with a big thick lip of tooth tissue at the base of our box, which is very difficult to manage and can only really be managed by going back in again with a burr and removing that. But then we also then have to upright to give us access, which makes things very big. A lot of people are worried about damaging the adjacent tooth as well and forget that actually just starting shy of the marginal ridge, but not fully in the mesial or distal pit, will mean that you can actually advance your burr down the long axis of a premolar or a molar tooth, and it will naturally perforate through and window itself below the contact point, at which point you can fracture away the remaining sliver of tooth tissue. These are the ways which, when we were all at dental school, we were told about, but actually are very easily forgotten when you get out there and practice and start having to do things on a time scale. And we actually just go in very close to the adjacent tooth with our burr, rather than remembering these principles. I'll talk again in the next webinar about features such as a flat floor, because a lot of people say we're using composite, we're bonding, we don't need those things anymore, but there are good reasons why we should still strive for those features, particularly not having any unsupported tooth tissue as well. And again, we could debate this a lot, but I still see real value in trying to have a little bit of undercut in our preparations, even though, again, these are going to be adhesively retained. And we'll talk more about that in, I think, probably the third webinar. Same principle applies for our kind of what were class 3s, our anterior approximal preparations, where we want to be in the middle third of the crown. We want to be essentially just around the contact point with our preparation. And again, leaving that thin sliver of enamel, which can easily be fractured away, so we're not damaging the adjacent teeth. With all the same features that we talked about before, wider at the base, minimal palatal access, and cavo surface angles of 90 degrees without any unsupported enamel. And how often do we really get chance to go back and try these things again, other than on a patient? So as busy practitioners, it's probably not often that you get the chance to really just play around with these things again. And that's why sometimes in-person hands-on courses are really valuable. I think what's also valuable is actually just having the opportunity to go to those kind of courses, have a phantom head and some teeth and not have an agenda and just actually play around with some stuff. It's so hard to get access to those kind of things now. So also I talked earlier about the adequate adaptation of matrices, because the type of matrix that you use can make a big difference. I don't know, obviously, what all of you use at the moment, but there are various choices to be made, and we'll talk about this in webinar 3. But it's going to determine your ability to manage excess material. It's going to determine your ability to achieve an anatomical contact point, and also how well your material adapts at the base of the box. All of those things are going to have direct implications for how either how much your restoration needs to be finished and how effectively it will be placed and how long it will last. And obviously for patients, the contour of the final restoration is important in terms of how it looks and how it feels. But for us, we're really talking about anatomical contour and making sure that we're not overbuilding or underbuilding restorations. And really, again, it's the interproximal contour which is really important. Dentsply, Sirona did some work, probably getting on for a couple of decades ago now, looking at polishing time, but really, really important seminal work around how a well-placed matrix, particularly a sectional matrix, can actually reduce the amount of time spent on polishing. We'll talk about this a lot more in the third and fourth webinars. So much more on that as we move through the series. If we're thinking about optimal bonding, this is something which continues to develop. It's amazing how the chemists and the scientists at all the companies, particularly at Dentsply Sirona, have come up with innovative solutions to help us overcome these problems. And at the beginning, I talked about the real challenge being the fact that we can't use amalgam like we used to in over wet environments anymore. We can't use composite like that. But I'll talk in the second webinar next week about how some of the science is being developed within these materials, which helps us there. It helps to accommodate some of the challenges that we have with over wet environments, but also in over dry situations as well. So your choice of bonding strategy will make a big difference to make sure that you're maximizing your bonding to all of the natural substrates that present, both enamel, dentine, tertiary dentine, sclerotic dentine, and making sure that you're able to effectively bond to all of those. And as I mentioned a moment ago, being able to cater for over wet and over dry environments. And, we've known for a long time in a lab that the traditional three-step approaches, etch, prime, and bond, are the most predictable and robust ways to employ bonding strategies. But actually in the clinical environment, they become some of the most technique sensitive ways and therefore aren't implemented particularly effectively. And we turn to simpler systems, which in theory will have slightly less bond strengths and inferior bonds, but actually clinically outperform because they're less technique sensitive, they're easier to use, and people tend to cut less corners or have less complications with using those materials. One of the things which, as academics, being a bit boring here, but I often used to talk about was when we're preparing cavities for restoring and we're getting our materials ready to bond to dentine is how do we know how moist the dentine surface is? We've just washed and dried the cavity, but what's the end point of drying? How do we know where the optimal amount of hydration is? Because we know that over-dried dentine collapses and that over-wet dentine will compromise significantly the bond with the resin, with the hydrophobic resin that we're trying to create. So I don't think that we would ever know as clinicians how hydrated it is. But these newer materials, which we'll talk about next time, are very clever in that they're taking that decision out of our hands. They are helping us to hydrate the surface or to rehydrate the surface to an optimal level. And also, you'll see next time how some of these materials now are helping us a lot in making sure that we've got marginal integrity of our restorations. And you might think that just by taking bond on your micro brush and rubbing it all over your cavity and curing it, that you are automatically ensuring bonding coverage of the entire internal surface of your restoration. But believe it or not, you're not. And I'll demonstrate some ways next time with some videos of how different bonding strategies are failing to do that and how some of these newer materials can help. And in turn, if we are able to manage the marginal integrity of the restorations, then often we are minimizing post-operative sensitivity. A lot of people think that post-op sensitivity with the composites comes from the C factor and from flexure on curing, and perhaps in some situations it does. But I'm a big believer, certainly having worked in this area for a number of years, that actually a lot of post-op sensitivity comes really from either early degradation or lack of adequate hermetic seal at the margins. And so we'll talk a little bit about that next time. In terms of contouring and handling, there's a lot of choice out there now with different composites, even within the dense glycerol family of materials, which we'll talk about in webinars 3 and 4. I've put some of those on the screen. We've got kind of Spectra ST, which is offering a range of different kind of packable composites for different situations. Some of them can just go in and have a relatively good chameleon effect, and we don't need to complicate matters with different layering. Some of them can be used with layering, and some of them can also be used in a more traditional flowable approach. And some of them can be used actually to put little effects into teeth and to restorations. But then we've also got a family of essentially what's called smart dentine replacement materials. They're kind of bulk cure, which have a great application now, which we'll talk about in the coming webinars. And the choice that you make along this different kind of portfolio of materials will make a big difference in any given situation. So, how easily can you sculpt the material into what you want? How easily will it adapt to the cavity that you want it to go into? How surface wettable is it? How will it help you by moving around the internal anatomy of a cavity? Will it maintain its position when you're trying to apply it to a cavity? Particularly around kind of the SDR flow, the flowables. We don't want that to be kind of dribbling anywhere before we cure it. And we don't want it to be slumping. We don't want to bunch material up to a piece of anatomy that we're then curing. And as we get there with the curing light, it's kind of slumping itself back down again. And we want to give something which has good aesthetics, particularly in the anterior zone as well. Really, really importantly, reducing the need for polishing. One of the things that we're still very trigger happy with generally as a profession is polishing back composites with discs and strips, and even with high speed polishing diamond burrs. But actually then all of that microparticulate is going down the waistlines. It's not being filtered out, and it's ending up in the environment. And really, we want to try and reduce the need for polishing. It's important to understand the difference between shaping and polishing. And we'll talk about that in the future webinars as well. We also don't want a situation where we're buying lots of materials and they're sitting in the drawer. And we'll talk about some of the ways in which Dense Splicer has thought of this, certainly by reducing down the number of components to some of its systems, and giving them more utility in any given situation. You'll all be aware of how frustrating it is when you open your composite box and the typical shades that you want the most are missing, and you've got the ones that you don't use the most, loads of them. So there's an opportunity to move away from that, and of course then they become wasted, and quite often they're just thrown away in clinical waste when they're out of date, particularly if they've already been in the surgery. And of course a lot of clinical waste is incinerated, and all of that is going into the environment. I want to mention here something about one of the last factors I was talking about, which is predictable restorability. As highly trained professionals, any of you can place a restoration, but is it a predictable thing to do? Is the outcome predictable? Will it last a long time? Because we have a duty to our patients to help inform them of how long things are likely to last, and actually whether we're recommending things or not. In the end, the patient has to decide, but they have to have informed consent. And this is probably most relevant in the future webinars when we're talking about those deep margins, for example, or losing a lot of tooth structure. But here we've got an example from Andrew Darwood, who a while ago now was talking about his dental practicality index for assessing the restorability of teeth. But actually, it's really important to know about things like this, because we're now finding that at the point where a tooth needs a restoration, if what you're placing is becoming unpredictable, it doesn't mean you shouldn't place it, but you should at least inform the patient, and you should make a note of that discussion in the clinical records, because there are lots of situations now where patients expect to be better informed. A lot of what we do, again, as highly trained professionals, is we make micro decisions in our heads, particularly in dentistry, from how much more tooth tissue am I going to remove? Am I going to remove any more in the body of the lesion? What matrix system am I going to use? What type of wedge? All these, I call them micro decisions. We're not talking to the patient about them, but at what point is that line blurred between informed consent and just as using our professional judgment. So the DPI gives a way of you actually applying something tangible to that decision around predictable restorability. So this takes time. Inevitably, we have to talk to patients about these things. A lot of our time now is taken up with discussions, which in the past wasn't the case, but it is important to make time. Again, most of you will be able to place a large restoration, but how long will it last? What will the complications be? And do patients understand those things? And are you happy it's the right thing to do? Sometimes, if any of you have some of the experiences I have in the past, you're placing a restoration and you're thinking, I'm not quite sure that this really is the best thing to do. It's always very difficult then to backtrack and start to have a conversation with the patient about, now actually this might not last as long as you think it would, or as we thought it would. It's much easier to have the discussion before you begin, and the patient saying, fine, I'd rather you tried, go ahead, I understand what the risks might be. And in turn, then we can demonstrate that we've got good patient consent. And when we get the complication, which inevitably we will with any restorative intervention, at some point, the patient is largely more on board with what's happening rather than feeling that this is just happening to them and we haven't told them about it. So you can see on the right here, we've got different levels of score that are attributed to different teeth in the mouth. We've got 0, 1, 2, and then 6. I'm not going to go through the whole index here, but it's an opportunity for you to have a little look at it. I thought I put a QR code up there, but I don't think I have, unless it's hiding under my box. No, it's not. But you can look that up fairly easily on the web, the Dental Practicality Index, and it's in the BDJ series of papers. In terms of deep margins, really, and I don't mean this in a patronizing way, obviously not anyone practically can elevate a deep margin, but as trained individuals, as trained clinicians, you could have a pretty good go at raising a margin on a tooth. But again, it brings us back to this concept of informed consent. Just because we can, does it mean that we should do it? What will the effects be? One of the things we'll look at in webinar 3 is what would the effects be of raising margins and placing restorations where we probably should have been more wary of that. Do we have a suitable way of predictably carrying out that procedure? And then on the back of it, do we have patient consent as well? And again, we'll talk more about that next time. So in summary, I hope I've kept most of you with me this evening, but what I'm saying is that modern composites can deliver very predictable solutions, both anteriorly and posteriorly, but all the factors we talked about tonight have to be respected in order to optimize your success. So it's not a question of whether you can place composites or not. It's how likely are you to be successful? Will they be robust? Will those restorations have longevity? And will there be a minimal number of complications? And again, here we're talking about the bonding techniques and the technology. We're talking about the type of material and the type of materials, equipment and matrices that we might use. So we were going to talk about how the phase down of amalgam will impact on our choice of restorative materials, and hopefully we've done that, and talking about the properties and indications for composites, and talking about what the challenges might be and some of the potential solutions in moving away from amalgam. And hopefully this has also given you some insight into what we'll do for the remaining 3 webinars as well. So I hope that's been interesting tonight, and appreciate it's the end of a busy day. Thank you for staying with us here tonight. And I'm happy to answer any questions that anybody might have about that.
That's absolutely brilliant. Thanks ever so much, James, for a really, really interesting presentation. So, yeah, if anybody does have any questions, please do feel free to either come off mute or pop them in the chat, and we're James or James will be more than happy to answer. Just while people are potentially thinking about having any questions, I've popped in some links in the chat for the remaining webinars in James's series, which we've referred to quite a bit there. As I say, the next one is same time next week. But in addition to James's webinars, I've popped some other useful links in there as well, both for our company website, which has the details of further events we've got on the restorative side of things. We've also got a link to our academy, which gives you access to lots of other on-demand restorative curriculum and various other webinars and things that you can have a look at if you're interested in furthering and finding out more about that. There's also a link to our Dentsply Sirona sales team, which is your local contact. So hopefully most of you will be aware who your local account manager is, but if you're not, if you click on that link, you can go via postcode, via dental sector, and it will tell you not only who is your local account manager, but also their contact details as well. So if you did want any further questions or a visit, that would be then we find that's the link to click to. And finally, I've just added both mine and Emma's email addresses in there. If you've got any specific product questions, Emma is absolutely brilliant as our national product specialist. Any questions on the education side of things or courses, please do feel free to drop me a line. But yeah, if I can ask again if anybody's got any questions for James while we're here.
It's not a question.
Steve.
Hi, James.
Hi, Steve.
Nice to see you again. I just thought
You
it was
too.
great how you brought in all of the aspects of clinical excellence and sustainability as well, because we know hand in hand that by doing great quality dentistry, that these things do last. Like that paper, do it once, do it right, and that brings good quality care. And it's just obviously something close to my heart, as you know, and I think it's just a great thing that Dentsply Sirona work alongside this principle. And still I'm technically a KOL for sustainability, and in DS World in Vegas, we did a couple of breakout sessions, and I think the message there is that we all want to do really good dentistry, want to use really good products, and obviously with the whole amalgam phase down and the use of composite, it brings with it its own sort of natural questions. You know, that are we going to place these composites? Are they going to last as long? I think you hit the nail on the head that the ISO standard sort of stuff with regards to the elution of monomers is something, obviously, you know, that with a bit of my background is, and I think one thing that was interesting, I'm sure will come into your future presentations, will be the polymerization sort of protocols. Is that something that you'll be talking about with regards to the composite side of stuff?
A little bit. It's not something that I really go into much of the science, and it's also something that it's not a focus that I've had, Steve. You'll be aware from the work you've done around the implications it can have with you know, with elution of different things, as you've mentioned, into the environment and into people's bodies. But I do think the ISO standards need to look carefully going forwards at what the requirements are, because it's just missing, as is kind of polymerization stress and shrinkage. Yeah.
No, so great. Busy day at work, and it's been good fun listening to this. And I didn't have my video on because you would have seen me eating pasta, which no one needs to see.
Thanks, Steve. Nice to see you.
You too.
Wafa has a question. Hi, Wafa. Nice to see you too. She's asked, to what extent and depth should we continue teaching amalgam, given that our undergraduates will likely work in an NHS setting and will still encounter it in their patients' mouths? Yeah, you're absolutely right. Certainly in the UK, I think the General Dental Council would be concerned if we didn't talk about amalgam at all. But like I was saying before, there's less need for students to understand the real science behind its composition, particularly if they're not going to be placing it, particularly, you know, in general dentistry. But they do need to understand how to manage it when they see it. We'll have amalgams which are still fracturing. We'll have amalgams which still need to be managed around the periphery. We'll have amalgams which need to be removed. And we also have amalgams which need to be bonded too. So yeah, we still need to talk about all those things and what strategies we can have and use to bond, to manage, to polish, you know, all of those amalgams which are out there. So you're absolutely right. There's a lot of it out there, and there will be for a while. Yeah. Thank you for that question.